We're going to talk about the mechanics of the adjustment first, and then we're going to talk about the patient placement and how to place the doctor's position with the patient. The patient does not hold us up. We don't hold the patient up. The patient placement is one entity, the doctor stance is another entity. Those two entities just come together. If you don't have those two come together efficiently, you're going to have trouble with these moves. We're going to talk about the doctor stance on the push move first. Doctor stance push move, we're going to address the lumbar spine today. Okay. You're going to have a stance where you have a little bit of pivot. Okay. Your back leg will be straight. Contract your quadricep muscle. Okay. A common area we run on with this adjustment is people bend the back knee and they do the body drop, bending that back knee, and they lose their stabilization, which causes the pelvis to rotate even more. And now we're going to introduce torsion to the spine. Do we ever want to have torsion in the spine? Absolutely not, because that torsion in the spine can actually tear angular fibers. So it's a stabilization leg. Has to be locked. Has to be locked. I'm going to have somebody say, well, I can't thrust in the air. If you can't thrust correctly in the air, you won't do it right on a patient. Okay? You have to get that coordination down. Okay? The front leg will be bent, and the body drop, and I'll do it slowly, is a vertical drop. I'm bending the front knee, which allows my body to go vertical, and I'm springing off the back toe, keeping the quadricep locked, keeping the knee locked. Notice it's a vertical drop. A lot of people throw their hip. They come in there and throw their shoulder and their hip. What's that going to do to your back all day if you're throwing it? You're going to tear up your spine. So imagine being in this position. Your tibia is about 90 degrees of the floor on the front leg. Knee is bent, quadricep locked, you're on the toe, and all of a sudden someone's going to strap 50 pounds to your belly button, you're going to drop straight down. It's like a trap door, drop it straight down. So that's the body drop. Then, we always, with the side posture work, adjust P to A, be it lumbars, be it PI iliums, be it AS iliums. You always adjust P to A. So the thrust is generic, we just change the position of the hand. So we stick the hand out, we're always supposed to P to A, tricep, pec, body drop. So it's just going with the tricep alone, or tricep pec alone, always thrusting back toward my midline, okay, then tricep, pec, body drop. Using my body mass, okay, and where's the segment always going to be? At my center of gravity, right underneath your belly button. If you're trying to do side posture, okay, up like this, you have no mechanical advantage. So always target that segment underneath your belly button. So you have to have a table that's built for your height. When you have your own equipment, it's custom made for you, that's real easy. In the Palmer clinic, sometimes you'll have trouble. Secret, for you people that are a little bit shorter, okay, toggle tables can be used for side posture. That puts the patient lower, you can get your center of gravity up over that patient. There's no law that says you can't use a toggle table for side posture. They are a little bit slick, but you can still get better than being up too high. So always have that segment right underneath your belly button, that's your center of gravity. Then, the stabilization hand takes a little bit of practice, has to hold still. I like one of these. Okay? Because too many people, when they thrust, they scissor the hands. If I push the shoulder back, I'm introducing what into the spine? Torsion again. We do not want torsion. So you have to learn to hold the stabilization hand still and just thrust with contact something. Any question on the mechanics of the push move? Okay. Pull move. Okay. Pull is actually a misnomer. It's a finger push. Finger push. Okay. If you want to get good at a pull move, take your speeder board, lay it on your thigh, set. Because there's nothing to what? Pull. Everybody follow? Okay. Now, have all of you used a hammer at one time in your life? The thrust is like a hammer. Our depth is from the forearm, the speed is from the wrist. So think forearm, wrist, forearm, wrist, forearm, wrist. Forearm's the depth, wrist is the speed. Just like you're hammering, hammers in your hands, or forearm, finish the wrist. Same thing. So finger set, finger set, finger set, finger set, finger set. Or think about a mosquito in your thigh. It's that fast. All of you had that mosquito bite you, you slap them, boom, boom. That type of speed you want to do the adjustment. But it's a finger set, finger set, finger set. We don't ever pull. And that's the disadvantage. Some people Actually take a right to left tissue pull, contact the spines, and pull and rotate the pelvis, causing, again, what in the spine? Torsion. We don't want torsion. We don't want torsion. Okay. So any question on the contact hand? Okay. The body, you have to learn to balance on one foot. Now, disadvantage of the class, you do a lot of setups, which take us 5 minutes to get down the row and check you. It's hard to hold a setup for 5 minutes. But guess what? You don't have to stand on one leg for 5 minutes when it's adjusting. Okay. You take your tissue pull, take your rolling, take contact, stretch your shoulder, up, 1001, set, down, 1002. So you're never on your feet for more than 5 seconds. So what I want you to practice at home is just going on one foot, count out to 1005, go to the other foot, count to 1005. Okay? You just practice that. Until you gain that balance, you have no business going to side posture. Because if you don't have that balance, you're going to lean on the patient's shoulder. You lean on the patient's shoulder, again, you cause torsion. Now, the side posture adjustments are designed for L4, L5, and the SI joints. We do teach them in the lumbar class 1, 2, and 3, but that'd be a last resort. That would be a last resort. Okay? Because in order to get L1, 2, 3, we do have to get a little bit of torsion in the spine. So that means we've tried single hand contact on the high low knee chest. We've tried double thumb on the high low knee chest. We can't get then, short term, try side posture. Okay? But L4 and L5 is where we primarily use a side posture, so you're going to stick that shoulder straight up. We do not want to stick the shoulder backward. If you stick the shoulder backward, you have a tendency to introduce what again? Torsion. Again, we don't want any torsion. Now, the kick is a very short, quick kick when you're on the patient. Okay? The direction of the kick is going to be towards your opposite leg, because you're actually kicking back into the bench. So I'll go through it slow, and I would never go this far, but think about the direction of knocking the other leg out from under you. You're getting a little bit of adduction, pardon me, okay? And a little bit of, think hip, external rotation. That's the direction you want. Now, you're never going to go that far, but that's the direction. Okay? It's a very slow kick. Your legs are only going to move a couple inches. Okay? Then put it all together, boom, 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 boom. Leg coming in, set. Any questions on the thrust? Now, the patient placement is critical. We're going to go through a lot of steps in the patient placement. If we have the PPP, perfect patient placement, okay, the adjustments get easy. I'm going to place Angie so she feels comfortable on the table. If she has any sensation rolling off the table, will she be relaxed? Absolutely not. Is there any sense even trying to adjust her if she's not relaxed? Okay, not at all. So it's very important, okay, that you have that perfect patient placement. So we're going to go through all the steps. Now, the question usually comes up, what about flexible patients? And I'm assuming Angie's probably going to be a flexible patient. Flexible patients adjust just like everybody else, but they're hard to hold a setup for 5 minutes. Again, knowing the difference between adjusting versus setups. Okay, there's really no difference adjusting a flexible patient compared to anybody else. Okay? But you can't hold them in that position for 5 minutes. Now, step one, and we're going to go through the steps very slowly, then I'm going to put it all together and finish it. First step is we have the inferior leg straight, foot off the end of the bench. It's very important that foot's off the end of the bench, particularly on push moves. Because as I roll Angie toward me for a push move, I want her toe to point toward the floor. If her foot would have to be on the table and I roll her toward me, that's going to cause tension in her legs. If she has tension in her leg, will she tighten up? Absolutely. So you always have to have the foot off the end of the bench. Step two, you want the toe in behind the knee. Now, not somewhere behind the knee, but shoe shine tight behind the knee. You understand? Because when it comes to push moves and pull moves, now just a little pull. When we give that kick, we have to have that foot snuggled in tight there. If I have her foot behind her knee and I kick, I'm kicking the slack. See the distance of her foot? By bringing that toe in, shoe shine tight, when I kick, her thigh stops very quickly. And that's a very, very critical part. Everybody have it? So when I say behind knee, I mean shoe shine tight. No gap at all. If a patient can't assume the position, we're not going to adjust them. So if you have a larger patient, the first they can get up is the big calf, they'll do side posture. You have to get that toe in behind the knee for proper stabilization. Now, next step is we want to tuck, and this is a real critical part, we want to tuck the lower greater toe canter, the one on the bench, in this case Angie's right one, anterior to the left. Not just anterior to where she lays down, anterior to the left. Because the average person will lay down with the knee point toward the table a little bit. You just have a little bit, not too much, a little bit of tuck, you're not ready. You want to tuck the pelvis underneath so that the greater trochanter against the table is more anterior than the top one. Think about the different types of pelvis, male pelvis versus female pelvis. Okay? Female pelvis is more rounded, so which one will we tuck more? Male or female? Female pelvis. Okay? You always want to tuck the patient so that the lateral thigh, and we're not there yet, okay, is just about parallel to the floor. On the female pelvis, you're going to tuck a little bit more. If the patient has any sensation of rolling, it should be onto their what? Onto their back. Everybody follow? Because part of the stabilization with the pelvic bench, okay, is having the bench against the wall. Because our stabilization is always coming back into the bench, and we want that bench against the wall as part of the stabilization process. So Angie, you ever scoot back a little bit? No, you're just too good. She automatically tucked the hip forward. So if she has any sensation of going anywhere, it should be onto her back. Okay? Now here's where you have to watch it on all patients, but particularly flexible patients. My next step is to fix her shoulders. The average patient, if you don't watch this next step, when they fix their shoulders, they roll their hips forward. So what you're going to do is you're going to come in and you're actually going to hold the patient's knee between your thighs. I'm going to place this hand on her iliac crest. She's pinned. She's not going to go anywhere. The average patient is going to lay down with the bottom shoulder close to the pillow and way anterior. So we want to start the patient shoulder on shoulder. Now see, as she fixes her shoulder, she wants to move the pelvis, but I'm not going to let her. Everybody have it? Then, key point. We pull the bottom humeral head, in this case Andy to the right, anterior, I should say slightly anterior, but big inferior to the left. These are traction leverage moves. If you don't have the right shoulder inferior to left, you'll never get that stretch on the patient's shoulder. So you always have to pull that bottom shoulder inferior and slightly, emphasis on slightly, anterior to the top. Then, the top arm runs down patient's side, so the point of the elbow is behind her midline. Okay? In this case, Angie has a shirt on, so if we look at the seam in her shirt, her elbow's behind that seam. Because as I stick her shoulder superior, I'm going to feel it tight underneath my contact hand. If I have the patient's arm forward and I push the backside of the shoulder, you'll never feel the stretch, and you're probably going to cause shoulder problems, number 2. Then, the left hand, in this case, goes on the forearm, and the patient's looking straight ahead. Okay. Good. So there's your patient placement. Okay. Again, all I'm going to do is roll her toward me and catch her with my thigh for a push move, and I'm going to go into my pull stabilization. So again, I don't hold her up, she doesn't hold me up. Everybody have it? Now, she should feel balanced there. If I have that greater trochanter tucked underneath, I can press that thigh and she's not going to go anywhere. Everybody have it? Any question on the patient placement? Because that is so critical. Okay. As we go through the hour, I might lose a little bit of patient placement with Angie since she is a flexible person. Okay, but we'll try to position her as we go. If you ever get uncomfortable, just let me know. Doctor's stance. You always have to end up with your thrusting hand between your legs. That's your center of gravity where your belly button is. Most people start with too dainty of a stance. They come with a real narrow stance, and by the time they pivot, they have all their weight on their superior leg. Now, I'll be demonstrating this on both sides. So we start off riding a big horse. Okay? So my inferior leg is touching her knee, superior leg is not. Everybody have it? We're just going to go through the mechanics of the adjustment first, then we're going to come back and go through contacts. So we're just going to talk about what we call dance steps. Okay? We learn to do dance. So we would take our contact, our tissue pull, our roll in. Once we do that, we stick the shoulder superior. I'll describe that in just a little bit. Then, your feet are frozen to the ground. Your feet will not move till it's adjusting time. So I'm going to roll Angie toward me to a comfortable working height for me. Another way to think of it is I have to roll her knee out of the way so I can sidestep superior. I've now shifted my weight onto the ball of my foot, my right foot. My anterior portion of her thigh, my thigh is on the lateral portion of her thigh. I basically have formed a V between the anterior portion of my quadricep, if you will, and the bench, and stuck her in that V. Now it's a soft stick, she's not going anywhere, so I'm not leaning heavy on her. Do I have it? You have to have the crease in your pants down the seam of their pants, so the patient's going to stay there. So we roll the patient over, sidestep, cover. Roll, catch, hit. Don't get to it. Roll, catch, hit. The segment, the lumbar segment, here, you straighten your legs, relax. The lumbar segment really never stops. You're rolling the entire body towards you. You catch her body with your thigh to keep the body, the patient's body, from moving, and then you continue on with your tricep contraction and set that one segment. Now, going through the contacts. I was going to do an L5, PL. Take a strong tissue pull, a little bit left to right, but big what? I to S. Again, you have to lift them before you set them. Have to lift them before you set them. So think I to S. Think I to S. Come right up underneath that fifth lumbar. Notice we have a modified arch. Okay? And test yourself. Push I to S. You should be stuck on that fifth lumbar. Then, key point. And you'll be able to feel it. Now back off. You're going to take the shoulder. You're going to stick it superior till you feel it pull underneath your hands. It's a big forgotten step. So I stick her shoulder superior till I feel it pull underneath my hand. I'm going to back off so we don't accidentally adjust her. I stick that shoulder superior. Everything's frozen. Her shoulder stuck up. I'm going to roll her over as one unit. Cover, thrust. Notice I roll her over to my center of gravity, catch her, get the arm out to drive what to what? P to A. If you want to have trouble side posture, keep your elbow in close to your body. Get that elbow way out so you're driving in P to A. So roll, catch, thrust. And keep in mind the speed is about 40 times faster than what we're showing you. For a mammillary contact, I was doing an L5, here S dash M. We're going to shift to L4. Here I dash M, take a strong tissue pull. It's just like a single hand contact. We're going to take I to S, big time tissue pull, a little bit of right to left, so here I dash M. I'm going to start with the hand crossing the spine, then roll in until I have the fingers running parallel to the spine. What will I feel right next to my hamate? Spines. If there's any space between the spines to your hamate, you're out in the muscles. That hurts. Again, we stick the shoulder superior till we pull underneath our hand. I'll back off again for our demonstration. Roll her over, get the arm out so you're setting P to A. Any question on the push move? Okay, now we're going to show you the dance step for the stabilization on the other side. Inferior leg straight, fall off the on the bench, superior leg flex, toe behind the knee, have the lower hip forward. Thank you. Spine. Now, notice my starting position. Broad stance. The inferior leg's touching your knee, superior leg is not. I take my tissue pull, take my roll in, take contact. I stick the shoulder superior until I feel it pull underneath my hand. I roll her toward me to a comfortable working height for me. Notice that my feet have not moved yet. We sidestep. As I sidestep, notice I go from a flat foot up on my toe, so I'm getting ready for my body drop. Spring on that back toe. It's set. So it's roll, little sidestep, placing the anterior portion of my thigh, lateral portion of the patient's thigh. Notice how tall I look on top of the patient, my belly button up over. Drop. Roll, catch, thrust. Roll, catch, thrust. Now Now here's where a lot of people have a problem. They pivot on that back foot. You pivot, number one, you're putting what in your spine? You're twisting your spine, torsion, and you don't have any what? Stabilization. As I thrust, I'm going to rattle everything. She's going to roll between my legs instead of me stopping her body. So roll, catch, thrust. Any question on the thrust? Any question on push move? Okay. The pull. The pull, you have to have perfect patient placement to do correctly. It's real easy to turn a pull move into a manipulation. Push move, you're going to roll the patient towards you a little bit anyhow, so if you don't have them tucked properly, you're probably going to still be all right. But if you have that patient's knee down toward the floor at all, you're going to introduce what? Torsion. Again, we don't want torsion. So really emphasize tucking that hip in on the pull move. So again, for the pull, same patient placement, inferior leg straight, foot off the end of the bench, superior leg flex, toe behind the knee. Again, shoe shine tight, just a little more tucked. Greater trochanter on the table is slightly anterior, the greater trochanter away from the table. I'm going to pull her right humeral head, inferior, slightly anterior to the left. Point of the elbow down the side of the body, so the point of the elbow is right behind her midline. Obviously, we'd have the patient in a gown, typically. Left hand on the forearm, patient looking straight ahead. So again, all we're going to do is superimpose this position on top of the patient. Her position should not move. Everybody follow, because if I lean on her, I introduce what? Into the spine again. Torsion. Do I have it? Okay. Now, we have to start with a broad stance, just like we did on the push move. As I shift my weight to one leg, I have to make sure that superior leg is underneath me. If I start with a narrow stance and I have both legs touching her leg, when I shift my weight, I'm going to have to lean on her shoulder to keep myself up. As soon as I lean on that shoulder, I'm going to automatically push it back, introducing what again? Torsion. Everybody have it? So start with a broad stance. You're just going to have to practice at home to find out what your stance is going to be, so when you shift your weight, you're going to be stable with that superior leg. Now, spinous pull move. What is the most important part of the spine we have to gain access to? Inferior. That's where a lot of people mess up on pulls. They get on the right side of the spinous for PR. It's the right. Inferior portion. You have to lift it before you set it. C2 to L5. You have to lift before you set. Lift before you set. Lift before you set. So think about the inferior portion of the spine. Scoot back a little bit. Now, I want to make sure we're not going to lose patient placement, so I actually going to over-tuck her just a little bit. L5, PR. I find that inferior tip of that spinous. I take a little bit of right to left tissue pull, but a big, what? Light S tissue pull. Now, you've been taught to stack your fingers in different directions. I promise you adjusting will make your hand stronger. Okay? I'm to the point now where the chiropractic index finger is all I need to adjust it, but until you get that hand strength, you'll stack them in some fashion. So I'm going to be using the chiropractic index finger. Take a strong IS tissue pull, a little bit of right to left, come in right behind. And as you can tell you, we're hooked on that spinous. The patient should know you're on that spinous, but it still should be a comfortable contact. I stick that shoulder superior, just want some hands you can feel it. Do you feel it pulling with your hand? If you can't feel that pulling with your hand, you're not doing this move correctly. So we're going to talk shoulder so I don't stress her. We stick the shoulder superior until I feel it pulling with my hand, not posterior because I don't want your distortion. Then the only thing that moves till it's adjusting time is my stabilization leg, shifting up, placing my knee just below her ischium, my shin the angle of the knee. So the patient's knees bent, forms a V, you're actually at the back side, the posterolateral side of that thigh. Notice that she did not roll when we took our stance. Then I'm going to be setting and kicking. There's the kick. It's not a big thing where she's rolling in this direction. Okay? Remember, stabilization is a counter force, just like your cervical adjustment. You have one hand that's a counter force, your stabilization hand. Your stabilization, the pull move, is also a counter force. the legs coming back toward the spine, your fingers coming toward the spine, so your stabilization contact, hand meet in the middle. Too many people make the mistake of kicking down. If you kick down, you're rolling the patient in the same direction you're trying to set. Can you set a vertebrate A if you're rolling a A? It's not going to happen. It has to be a counter force, back into the bench. So again, for a spinous pull, strong IDS skin pull, come underneath with my chiropractic index finger, stick the shoulder superior, come in, set. Now for a mammillary, I'm going to run down the fingernail to check the segmental contact point. What should I feel? Spinous. That's how tight you have to be on mammillary. If there's any gap between the tip of your finger and that spinous process, you're not on mammillary. So L4, PRI-M. On the L4 spinous, your spine space above, I take tissue pull, a little bit of right to left, but a big what? I to S. Finish with a strong roll in. Run right down my finger. There's the spinous. We stick our shoulder superior. I feel a pull underneath my contact hand. We're going to emphasize this a lot. If you don't feel that pull, again, you're not going to adjust it. I shift my weight up, so my weight support on the superior leg. My knee is just below the ischium, the shin and the angle knee, then set. To show you the stabilization on the other side. Again, we start with a broad stance, so my superior leg is superior enough so when I shift my weight, everything's going to fall on that superior leg. We take our tissue pull, we take our roll in, we stick the shoulder superior until I feel a pull with my hand. Then we bring the knee just below the ischium, the shin, and the angle of the knee. The pressure as you feel is just like my hand coming in here. The shin has control, going back into the bench. Not in this direction, you're going to roll her. Okay, so it's back to the bench. My fingers are thrusting this way, I'm going to meet her in the middle. So notice when we mount up that we don't lean on the patient. We keep the patient's position the same. Everybody have it? Then going through it slowly, this direction. Now the leg will come down a little bit because you're above it, but don't you try to go down, you try to go towards the opposite leg. There's the direction of the kick. So real kick with Nancy's permission. Any questions on the pull? Question?
Clinically speaking, is it ever beneficial to use two-finger contact?
Two-finger contact? You have trouble getting two fingers on a mammillary.
Okay, are these all mammillary moves?
Now the first one was spinous, then it's mammillary.
Okay, first spinous move?
Because what's the emphasis of the SCP? Inferior portion. The spinous isn't anywhere in my little finger. You can't get two fingers on the inferior portion. No. One finger. Any questions?